National Safe Motherhood Day is observed annually on April 11th in an effort to promote improved maternal health and reduce maternal mortality rates nationwide. The For Her With Her campaign by Alembic CSR is an initiative that aims to empower women by educating them about their health. And maternal health and safety is one such critical topic. So to shed more light on the subject this National Safe Motherhood Day, I'm joined by a highly distinguished panel of domain experts. Allow me to introduce our guests. We have with us Dr. Jaideep Tank, President, Federation of Obstetric and Gynecological Societies of India. Dr. Rishikesh Pai, former President, Federation of Obstetric and Gynecological Societies of India. Dr. Madhuri Patel, Secretary General, Federation of Obstetric and Gynecological Societies of India. And Dr. Parikshit Tank, Treasurer, Federation of Obstetric and Gynecological Societies of India. Doctors, thank you so much for taking the time to speak with us. And Dr. Jaideep, I'd love to kick off the conversation with you. For the benefit of our viewers, what essentially constitutes safe motherhood? What are the requisite services that it typically encompasses?
Safe motherhood actually is a very, very, very broad term. And I think it's also a bit of a misnomer, because safe motherhood actually starts much before motherhood. If you really think about it, a woman should be prepared for motherhood much before she actually starts attempting to become a mother. In my view, it actually starts in childhood and adolescence, where she should be prepared to address issues like menstrual hygiene, anemia, heavy menstrual bleeding, and so on, and try and ensure that she enters motherhood in the best possible shape. So it starts from there and then continues into the care of her when she is pregnant, which constitutes antenatal care, all the checkups that are required, all the tests that are required to make sure that she and the fetus are growing well and are safe and are normal, and then continues to her care during labor and delivery, where she actually delivers or she actually gives birth, which is a better term than delivers, and continues on to the puerperium or the post-pregnancy part, where we have to encourage her to breastfeed, take care of the child, ensure adequate vaccination for the child and growth and so on. But the International Safe Motherhood Day actually has a very interesting history. It was actually started in 2003 by the Government of India, and April 11th, which marks the National Safe Motherhood Day, is actually the birth anniversary of Kasturba Gandhi, who was, of course, Mahatma Gandhi's wife, and that's why the government decided to mark this in the calendar as Safe Motherhood Day. And what the Safe Motherhood Day hopes to achieve is actually raise awareness on the issue, use it as a day for advocating for safe motherhood, and also try and identify what gaps are remaining in our country and fill those gaps.
Absolutely. And I want to build on some of your observations and pose my next question to Dr. Pai. And in a country like ours, what are some of the obstacles that are in the way of making safe motherhood, as Dr. Jaideep has defined it, more mainstream? And how do we address those challenges ultimately?
So India is a large country. It's nearly 1.4 billion, and it is very variegated country. You have got urban, rural, there are so many villages where there is no access. So biggest problem. So, and you'll be surprised, we do nearly 26 to 30 million deliveries every year.
Phenomenal.
So it's a huge amount of people who are delivering. And the biggest thing is the education we are still improving ourselves. A lot of goals have been achieved, but we need more education. We need more information. That's another hurdle, that people have not got the information.
Right.
Access is a big problem. Large swaths of land, it's very difficult to transfer patients. So accessibility is a problem in the in the rural areas. And of course, then there's a barriers also at the level of the hospital. So the staff, so there's a lot of interaction with the staff. Staff has to be educated in a different fashion to be more empathetic, compassionate to the patients. The healthcare workers have to be more educated. So there are a lot of barriers, but these barriers are slowly getting overcome.
Right.
In the present day, a lot of new programs have been instituted both in the private and in the public space. Like we have the Lakshya program of the government in the public hospitals and the Manyata program in the private hospitals. So a lot of things are being done to overcome these barriers.
Sure. And if I could come to you now, Dr. Madhuri, we've just heard from Dr. Rishikesh. He's touched on accessibility, affordability, and perhaps limited awareness, which is what leads to extremely low last mile implementation. So unfortunately, even in the context of maternal health, there's an urban-rural divide that exists in our country. How do we better bridge that gap?
Thank you, Pooja, for the very good question. But before I answer your question, I would like to mention about my organization. We are the Federation of Obstetrics and Gynecology of India. It is known as FOGS. We are having 275 member bodies, like Mumbai is one of them, and 43,000 plus members committed to women's health.
Right.
So as now coming back to your question, that we have so many programs we can do. One is continuous medical education, where we ourselves can go over there in a rural area and train them, educate them. Secondly, we can have webinars. Nowadays with the COVID, we have learned the webinar is very, very good system to update the knowledge of everybody.
Sure.
Thirdly, we have our journal, what you call as Journal of Obstetrics and Gynecology of India. It is on a digital platform as well as on the printed form. So in a rural area where they are not digital savvy or where the internet is a problem, we send the printed copies to all our 43,000 members free of cost. So they can read, they can update, and they can implement to the patient for the better outcome of women.
Absolutely.
One more thing I would like to say, that as Dr. Rishikesh has pointed out, Manyata is our flagship program. As 35 to 40% of the delivery occurs in the private sector, and those private sector with the small nursing home and especially in rural area, they can never update themselves apart from this which I have said previously, but Manyata, they have to register with us. As a whole team, obstetrician and the paramedics, we teach them online, offline about the antepartum, intrapartum and postpartum standards. So they implement that, and in that if they are 85% up, we give them certification and quality care for the mother during the intrapartum period. So this is a way we can bridge these gaps in many, many aspects, and we can definitely reduce. We can give quality care as well as we can reduce the maternal and perinatal mortality.
I feel that the urban-rural divide has essentially got a few components that need to be addressed separately. For example, there's the component of infrastructure. Obviously, the infrastructure which is available in an urban setup is much more than the infrastructure that's available at the rural setup.
Absolutely.
And perhaps to bridge that divide, what Rishikesh said about access would be one of the most important things. So when we look at the roads and the highways being built across the country, besides easy transportation, let's not forget that these good roads and highways also save lives.
Right.
Because transporting someone from a rural area to an urban area becomes so much easier when you have good roads. The person in need of health reaches the urban area faster.
Of course.
There is also the aspect of human resource. And human resource in our country is typically concentrated in urban areas. And perhaps something like telemedicine could be used to bridge the urban-rural divide over here. And there is this third aspect of awareness. It's unfortunately a myth or a narrative that people of a certain socio-demographic strata are not as aware or are not as concerned about their health as others. But
Right.
there is more than enough data to show that people across socio-economic strata are equally concerned about their bodies and their health. It's just that we need to find different ways and better and nuanced ways to address different populations. So what works in an urban area for awareness may not work in a rural area for awareness.
Absolutely.
And perhaps this nuance is missing, and this nuance may be required to fill this urban-rural divide.
Well, I want to talk about that nuance, and I want to bring Dr. Parikshit into the conversation now, because Dr. Parikshit, as we've just heard from all three of our panelists that you are sharing space with, we live in a heterogeneous India, right? So what role do cultural influences typically have when it comes to maternal healthcare related decisions and maternal health behaviors? And how can we perhaps rework the messaging around maternal health best practices so it's more culturally sensitive?
So, thanks, Pooja. I mean, when we talk about culture, culture is essentially a set of behaviors and expectations in a society or a population. And what we are doing now is cultural enhancement. We are mainstreaming safe motherhood right into TV sets, which can reach the entire population. So what we need to do is enable cultures which are health influencers, things which will make people look at safe motherhood in a more positive light. That's what we are aiming for. And of course, old styled myths which may exist in certain cultural situations, those need to be rid of. That's what cultural enhancement and prioritization is all about. So essentially, a culture which is for her, with her, is what's going to take us forward as far as this aspect of safe motherhood is concerned.
Dr. Jaideep, I want your perspective, given your 4 decades in medicine, all right, on interventions perhaps that you think have been particularly transformative in the context of maternal health monitoring.
A safe motherhood is a package of interventions, and typically what works is a package rather than a single intervention. If you look at the reasons why mothers die, in our country, for example, the most common reason why mothers die seems to be either postpartum hemorrhage, that is bleeding after delivery, or pregnancy-induced hypertension, which is a high blood pressure in pregnancy, or infection after pregnancy, which is called puerperal sepsis. And therefore, if I had to say which is the single most important intervention, I would have to say it's emergency obstetric care, or it is better care of the woman when she is in labor and delivery, and the immediate 1 hour after she delivers. So the interventions which constitute the package for emergency obstetric care, labor and delivery, and immediate post-delivery care, according to me, have the single biggest impact on what your maternal mortality ratio is going to be. Having said that, as I already said earlier, safe motherhood is a package which constitutes a continuum of health or a continuum of services. And within this continuum of services, perhaps what has been underappreciated is the contribution of contraception. And that is the ability for a woman to choose when she wants to get pregnant.
Right.
And the access to abortion, where the woman can choose whether she wants to continue the pregnancy or not. I think these have been underappreciated as interventions which lead ultimately to safe motherhood. Contraception, for example, every time the mother has an unplanned pregnancy, her chances of having a problem during that pregnancy increase. Contraception, and there is extremely and extraordinarily safe and effective contraception which is available now, allows the mother to choose when to get pregnant, allows her to choose the time, allows her to choose where she would like to get pregnant, and so on and so forth. And therefore, literally, contraception saves lives.
Right.
And this has been underappreciated because contraception is linked with someone not getting pregnant rather than getting pregnant.
Sure.
So when we talk about safe mother, it's all about the pregnancy. But what happens before the pregnancy is also equally important.
And I want to switch gears for a moment, and I'll come to you now, Dr. Madhuri. Help me better understand what are some of the telltale warning signs of a potentially future complicated pregnancy, right? So that women can better understand, address, and preemptively prevent an adverse outcome.
So the warning sign, as far as the patient and the family members are concerned, they should know when they have to seek the advice from the consultant or the healthcare worker or the healthcare professional. So any vaginal bleeding is a warning sign. They have to immediately go to the doctor. Secondly, in the first trimester, there is vomiting, nausea is very common.
Right.
But when there is excessive, what we call as hyperemesis gravidarum, that is bad. That can harm the mother because she can go into dehydration and ketoacidosis. So every time we explain to the patient, the community and family member, this is a normal phenomenon. But when there is excessive, they have to seek the advice from the healthcare worker. Thirdly, when patient gets swollen up, there is swelling of the face, there is swelling of the legs, there is headache, there is vomiting along with that. That is a warning sign. So before that, the swelling of the face and legs, you should understand whether it is this anemia or what you call as pregnancy-induced hypertension. As Dr. Jaideep has rightly pointed out, the first most common causes of maternal mortality is postpartum hemorrhage, and second is pregnancy-induced hypertension.
And I want to come to you now, Dr. Parikshit, because there's one subject we haven't quite done a deep dive on, and that is telemedicine. All right? So while we've talked about the urban-rural divide, look, the problem is multifold, in that not only is there subpar infrastructure, but even if a woman from one of India's most marginalized communities or rural corridors were to make it to a facility, right, you run the risk of it being understaffed or having severely untrained medical professionals, right? So to what extent can telemedicine come to our rescue?
So I look upon telemedicine as a bridge, really, which can, bring patients closer to health infrastructure, as well as get people or service providers who are in situations where adequate backup is not available, seek advice from other health professionals who are better equipped. At the moment, what I feel is that telemedicine has one very big and very achievable low-hanging fruit type of a goal, and that is nudging good health behavior. I mean, setting reminders to visit for immunizations, for supplementations, making sure that the baby, once it's born, is adequately breastfed, giving some health tips. Now, this is very easy to do by telemedicine. So at the moment, I see this as very achievable. As we broaden the scope of telemedicine, it can be extended to maybe consultations from where there could be a supplementation with a physical visit from a local healthcare provider,
right,
seeking advice from a bigger center, and then implementing it at a local level, something like a hybrid kind of a telemedicine.
Right.
And of course, as things evolve, as the scope of this broadens, then there could be a more in-depth, deep dive into this whole thing. And that could take us into a whole new vista once AI comes in.
Sure.
So lots of scope, but probably a graded approach towards
We
it.
look forward to that. And coming to you now, Dr. Jaideep, as seasoned medical professionals on this panel, right, you all have studied the leading causes of whether it be maternal or neonatal morbidity, mortality, etc. But how can we better educate the general public of the benefits of, for example, delivery by skilled birth attendants, or the risks perhaps that are associated with even attempting an at-home delivery?
I think this builds very nicely on what Parikshit and Rishikesh and Dr. Patel have just spoken, because it actually takes the whole ecosystem into account.
Right.
And it's unfortunate that we look upon patient awareness in silos and address it homogeneously across the country. I think you said India is a heterogeneous country. I couldn't agree more with you. One of the key things that we can do to educate the community better is uniform messaging.
Sure.
It seems to me that even now, messaging which is conflicting sometimes goes out to the community.
Right.
With one person saying this, the other person saying that. So reliable, authenticated sources of information would be from where you start. And I think that's where campaigns like For Her, With Her, associations of professionals like us, the
Right.
Federation of ONG Societies of India, can really play a very, very important role. The messaging also needs to be nuanced to the local context. It needs to be nuanced to the local language, and it needs to take into account the living conditions. For example, the advice that you give someone in an urban setup may not be the same that you give advice in rural.
Absolutely.
Warning signs in rural areas with poorer access have to be actioned upon much earlier, because it takes that much more time for that person to reach the healthcare facility. And that's another thing So the messaging not only has to be nuanced, it also has to be non-stigmatizing.
Right.
And I'm always very concerned about this. For example, we sometimes try to tell pregnant women that do this or this will happen to your baby. Now, we don't understand the significant mental trauma that a woman may have if per chance she happens to do something which she's been told not to do. Right. Something as simple as eating papaya. In pregnancy, patients always ask me, Doctor, are garam pad se? And there is this whole thing about heat in the body and so on and so forth. And women agonize over these things. I get calls sometimes in the mango season, can I eat mangoes? Sure. Now, this should not be something which a patient needs to ask. This should be something which should be self-evident. Right. And we should tell patients that there is literally no food that you absolutely need to take, and there's absolutely no food which you absolutely need to avoid. Right. I'm not talking about, drinks and cigarettes and so on. I'm talking about food, right? So, non-stigmatizing messaging. So, I would say authenticated, reliable, I would say uniform, and non-stigmatizing messaging is the way to go forward to educate the community. And then, of course, you need to take the second step on how to reach the community. Right. And I think that nowadays with, social media and WhatsApp forwards, instead of sending, those regular good morning WhatsApps with flowers, etc., we could consider populating these WhatsApp groups with messages which are more positive about motherhood, right, which enhance autonomy for women, which talk about women's choice, which talks about their ability to undergo a safe and, dignified pregnancy and childbirth. So these are just some of the things, actually communication is a massively underappreciated or topic. Right. Because communication encompasses all these things, and what you say may not be what is understood. Absolutely. And I think you need to close this loop, right, of communication by asking the person to whom you're communicating, I told you this, I meant this. Did you understand this or did you understand something else? Right. So I think it should be a closed loop system. Sure. Well, I believe that makes for a wonderful note upon which to close. So that's it, Dr. Jaideep, Dr. Rishikesh, Dr. Madhuri, and Dr. Parikshit. Thank you so much for taking the time to speak with us. We salute your efforts and we wish you all the continued success.